Welcome to the deep dive. Today we're tackling something incredibly fast-paced: acute stroke and transient ischemic attack, or TIA, management. We're looking at how emergency medicine triages these cases where, every second counts, literally.
It really does. It's arguably one of the most time-critical situations in all of medicine. Understanding the pathway, the steps involved, really highlights why that speed and sticking to the protocols is just so vital for the patient.
Okay, so let's lay out the groundwork. We hear these terms a lot. We've got basically three main things we're talking about.
That's right. Two kinds of stroke. First, hemorrhagic stroke. That's when a blood vessel actually ruptures inside the brain, bleeding.
Okay, a bleed. Got it.
And then ischemic stroke. This is the much more common one, where an artery gets blocked, cutting off blood flow.
Blockage versus bleed. Simple enough. And the third one, TIA.
Right, the transient ischemic attack. People often call it a mini stroke. The key thing here is the blood flow gets interrupted, causing stroke-like symptoms, but it's temporary. The symptoms resolve, and crucially, when we do follow-up imaging, there's no sign of permanent damage, no infarction. That's the defining feature.
Okay, important distinction. So our mission today is kind of mapping out that whole journey, right? From when symptoms first hit, through the assessment, and onto those really time-sensitive treatment calls.
Exactly. And it starts the second that patient hits the door. We're doing assessment and stabilization simultaneously, really. The absolute first priority is always the ABCDE's airway, breathing, circulation, disability, exposure. Is the patient stable or unstable?
Right, first things first.
If they're unstable, everything else waits. We stabilize. That might mean intubation, getting IVs in, fluids, constant monitoring of vitals. And if we suspect a bleed, like a hemorrhagic stroke, managing high intracranial pressure becomes a huge focus immediately. That pressure can cause damage fast.
Makes sense. You can't fix the stroke if the patient isn't stable overall. So let's assume they are stable. What's the next step? The detective work begins.
Yep, and the single most critical bedside test you must do right away.
I think I know this one. Blood sugar.
Fingerstick glucose, absolutely non-negotiable. It's a classic teaching point because hypoglycemia, really low blood sugar, can perfectly mimic stroke symptoms. Weakness, confusion, slurred speech.
So you could go down the whole stroke pathway by mistake.
Exactly. You have to rule it out first. Once that's clear, then we dive into the history and symptoms. What did the patient or bystanders actually notice?
And we're looking for those sudden onset focal neurological things?
Precisely. Sudden weakness or numbness, especially just on one side of the body. Trouble speaking or understanding speech. Facial droop is a big one. Sudden vision loss. Dizziness, loss of coordination. And we listen carefully to how they describe any headache.
You mentioned a specific type earlier.
The thunderclap headache. If someone says it's the worst headache of their life, came on instantly, like a clap of thunder that screams subarachnoid hemorrhage, a specific, often very dangerous type of bleed.
Okay, that's a major red flag. Beyond those acute symptoms, what about the background? The chronic risk factors, are they the same for bleeds and blockages?
There's definitely overlap. The big four are risk factors for both: smoking, diabetes, high cholesterol, and maybe most importantly, high blood pressure. Hypertension damages vessels over time, leading to both kinds of stroke.
So hypertension is a double threat.
Absolutely. Then you have factors more specific to blockages, things like known heart problems, especially atrial fibrillation, that irregular heartbeat that can send clots up to the brain, carotid artery disease, narrowing in the neck arteries, and less common things like hypercoagulable states where the blood clots too easily, or even substance use cocaine, amphetamines can cause spasms or bleeds.
Okay, so suspicion is high. We've checked the sugar, got the story, done the exam. Now we need to look inside the head. What's the immediate imaging needed?
Non-contrast head CT stat. That's the absolute key first imaging test.
Yeah.
It tells us the most critical thing first. Is there blood? Is it a hemorrhagic stroke? Because we cannot give clot-busting drugs if there's a bleed.
That's a big fork in the road, isn't it? Bleed or no bleed.
Exactly. And while that CT is happening or right after, we're usually starting the rest of the workup too, maybe vessel imaging like a CT angiogram, an echocardiogram to look at the heart, blood tests for cholesterol, HbA1c for diabetes control, and so on, trying to figure out the why.
Let's follow that fork. Say the CT does show blood, hemorrhagic stroke. You mentioned cause can vary with age.
Yeah, it's a pattern we see. In younger patients, maybe under 50 or 60, a bleed might be from an underlying vascular abnormality they were born with, like an arteriovenous malformation, an AVM, or an aneurysm that ruptured. In older patients, it's more commonly linked to the effects of chronic high blood pressure damaging small vessels over decades, or sometimes this condition called amyloid angiopathy.
Amyloid angiopathy, what exactly is that?
It's a condition mostly in older adults, where a protein called amyloid builds up in the walls of the brain's arteries. It makes the vessels stiff, brittle, and very prone to rupture, even without super high blood pressure. It's often linked to recurrent lobar hemorrhages, meaning bleeds in the outer parts of the brain.
Okay, so if it is a bleed, what's the immediate management plan? Forget clot busters, obviously.
Right. The focus shifts completely. It's about damage control. Carefully managing blood pressure, not too high, not too low, reversing any anticoagulation immediately if they're on blood thinners, and getting neurosurgery or neurointerventional radiology involved right away. They might need to monitor the pressure inside the skull, maybe even place a drain to relieve pressure from blood or cerebrospinal fluid.
Makes sense. Now the other path, the CT is clear of blood. We're thinking ischemic stroke, a blockage. This is the majority of cases, right?
By far, about 85% of strokes are ischemic.
So what are the main culprits here? What's causing the blockage?
Again, several possibilities. Cardioembolism is a big one. A clot forms in the heart, often due to atrial fibrillation, breaks off and travels to the brain. Then there's large vessel disease, atherosclerosis, plaque buildup, usually in the carotid arteries in the neck or the major arteries inside the brain, causing severe narrowing or occlusion, hypercoagulable states we mentioned. And then there's a really important category called lacunar strokes.
Ah, yes, the lacunar strokes. They sound small but can be devastating.
Exactly. They're small infarcts, tiny areas of damage deep inside the brain, places like the basal ganglia, thalamus, pons, internal capsule. They're caused by occlusion of the very small penetrating arteries that feed these deep structures. And the cause is almost always chronic damage from long-standing hypertension, diabetes, and smoking. They really underscore the impact of those chronic risk factors.
A stark reminder. And you also mentioned some less common causes, particularly in younger people.
Right. Things we think about, especially if there isn't a clear traditional risk factor: carotid or vertebral artery dissection, a tear in the artery wall. This can happen spontaneously or sometimes after neck trauma, even things like chiropractic manipulation in rare cases. And in young patients with otherwise unexplained stroke, we often look for a patent Foreman oval, or PFO.
That's the hole in the heart.
Sort of, yeah.
Yeah.
It's a small opening between the top two chambers of the heart that normally closes after birth. If it stays open, a clot from the venous system could potentially cross over to the arterial side and go straight to the brain, bypassing the lungs, which would normally filter it out.
Okay, so we've established it's likely ischemic, no bleed on CT. Now we hit those critical treatment decisions, the real race against the clock. First up, 4V thrombolytics, the clot busters.
Yep. Intravenous thrombolysis, usually with drugs like Alteplase, TPA, or sometimes tenecteplase now. These are enzymes designed to dissolve the clot and restore blood flow.
But the clock is ticking loudly.
Extremely loudly. The standard window for 5E TPA is within 4.5 hours of the time the patient was last known to be well, or their normal baseline. 4.5 hours. That's it.
Why so strict?
Because after that point, the risk of causing a dangerous bleed into the area of the stroke, what we call hemorrhagic transformation, starts to outweigh the potential benefit of dissolving the clot. The brain tissue is too fragile.
So 4.5 hours is the hard limit. But even within that window, not everyone qualifies, right? There are tons of exclusion criteria.
Oh, absolutely. It's a long checklist.
Right.
First, blood pressure has to be under control specifically, less than 185 systolic and less than 110 diastolic. If it's higher, we have to try and bring it down carefully, but if we can't get it below that threshold, they're out.
Okay, BP control is key. What else?
Any sign of current bleeding, obviously. Recent major surgery or trauma, especially head trauma or neurosurgery within the last 3 months. History of intracranial hemorrhage ever. Known brain tumors or AVMs. Recent significant GI bleed, like within 3 weeks. And specific blood tests matter too if their blood is too thin already, like an INR over 1.7, or if their platelet count is too low, below 100,000. We have to be incredibly careful not to cause more harm.
Wow, it's a really tight needle to thread. So what if they miss the 4.5-hour window, or they have a contraindication, or maybe the clot is just too big and unlikely to respond to IV TPA? Is that where mechanical thrombectomy comes in?
Exactly. Mechanical thrombectomy has been a complete game changer in stroke care. This is where we physically go in and remove the clot.
How does that work?
Neurointerventional specialists thread tiny catheters up through the arteries, usually starting in the groin, all the way up into the brain. They use devices like stent retrievers or aspiration catheters to literally grab or suck out the clot.
And the time window for this is much longer.
Much longer. For eligible patients with a large vessel occlusion, meaning a blockage in one of the big arteries confirmed on imaging, like a CT or MR angiogram thrombectomy, can potentially be done up to 24 hours after symptom onset.
24 hours versus 4.5 hours, that's huge.
Okay.
But how do you decide if it's worth doing, say, 18 hours out? Isn't the brain tissue likely dead by then?
That's where the concept of the penumbra comes in. This is absolutely critical. The penumbra is the area of brain tissue surrounding the core infarct, the part that's already dead or dying. This penumbral tissue is stunned. It's not working properly because of severely reduced blood flow, but it's still potentially salvageable if we restore flow quickly enough.
So it's like brain tissue on the brink.
Precisely. And we can often visualize this penumbra using advanced imaging like perfusion scans on CT or MRI. These scans can show us the mismatch between the area with severely reduced blood flow, the larger penumbra, and the area that's already infarcted, the smaller core. If there's a significant amount of salvageable penumbra, even many hours out, it justifies going after the clot with thrombectomy to try and save that tissue.
That makes so much sense. It's not just about the clock, it's about how much brain is actually still viable.
Exactly. It's about saving brain real estate.
Okay, let's shift gears slightly. What about patients whose symptoms completely resolved before they even got treatment, or maybe they had a very minor stroke? The TIA folks or near TIAs?
Right. For them, the immediate emergency treatment phase might be over, but the urgency shifts to secondary prevention. How do we stop this from happening again, and potentially much worse, next time?
So what are the first steps there?
Blood pressure management is still key, but it gets a bit nuanced. If their blood pressure is sky high, say over 220, 120, we actually need to lower it slowly and carefully.
Slowly. Why not bring it down fast?
This is that paradox we touched on. Right after an ischemic event, the brain's ability to regulate its own blood flow can be impaired. If you drop the pressure too quickly, you might actually reduce blood flow to those vulnerable areas, potentially causing symptoms to return or worsen. It's called hypoperfusion.
So you allow permissive hypertension for a bit. Let it run higher than you normally would.
For a short period, yes, especially if they didn't get TPA or thrombectomy. We might tolerate pressures up to 2020 initially to ensure adequate perfusion to that potentially stunned tissue, that penumbra. But this is temporary. The long-term goal for absolutely everyone is strict blood pressure control, ideally below 20/80.
Okay, that's a critical distinction. How does the BP management differ if they did get TPA?
Then it's much stricter right away. Because TPA increases bleeding risk, we need to keep the BP lower, typically below 180 or 105 for the first 24 hours after giving the drug.
Got it. So permissive hypertension only if no TPA or thrombectomy. What about medications like aspirin or blood thinners for prevention? When do those start?
If they receive TPA, we have to wait 24 hours before starting antiplatelets, like aspirin or clopidogrel, or anticoagulants, like warfarin and newer agents. Again, it's all about that initial bleeding risk from the TPA. If no TPA was given, we usually start antiplatelet therapy pretty quickly for most ischemic strokes.
And what determines antiplatelet versus anticoagulant?
It depends on the cause of the stroke. If it was likely due to atherosclerosis or lacunar disease, antiplatelets are the standard. But if the stroke was caused by cardioembolism, usually from atrial fibrillation or a known hypercoagulable state, then they need full anticoagulation, which is more potent than antiplatelets. Statins, the cholesterol-lowering drugs, are also typically started right away for almost all ischemic stroke or TIA patients, regardless of their cholesterol levels initially.
Okay, let's circle back to imaging for a second. You said the initial non-contrast CT is mainly to rule out a bleed. What if that CT is normal, but the patient clearly had stroke symptoms, even if they resolved? Can we say, okay, no stroke?
Absolutely not. A standard CT can be completely normal in the early hours of an ischemic stroke, sometimes even for a day or two. The damage might just be too subtle initially. Your clinical diagnosis is still driven by the symptoms and the neurological exam. If someone presents with classic signs, say weakness on the right side and inability to speak, you strongly suspect a stroke in the middle cerebral artery territory on the left side, even if the initial CT is clean.
So, if the symptoms resolve completely and the initial CT was normal, how do we officially distinguish between a TIA and a very small stroke that just didn't show up on CT yet?
That's where follow-up imaging, specifically an MRI of the brain, becomes crucial. An MRI is much more sensitive than a CT for detecting small or early ischemic changes. If the patient had transient symptoms, but the later MRI shows a definite area of infarction, a spot of tissue damage, then by definition it was an ischemic stroke, even if the symptoms got better. Only if the MRI is also completely clear, showing no infarction, can we truly call it a TIA.
So the MRI is the final arbiter between TIA and stroke if symptoms resolved. That's a really important point.
It is, because the implications for future risk and management might differ slightly.
And for those patients confirmed to have had a TIA, is there a way to estimate their short-term risk of having a full stroke?
Yes, there's a widely used clinical tool called the ABCDE score. It helps us risk stratify patients after a TIA. It assigns points based on age, older is higher risk, blood pressure on presentation, higher is higher risk, clinical features, certain symptoms like weakness score higher than just sensory symptoms, duration of symptoms, longer is higher risk, and presence of diabetes.
And a higher score means?
A higher score correlates with a significantly higher risk of having a major stroke within the next few days to weeks, up to 90 days out. It helps us decide how aggressively we need to manage them. Do they need immediate admission for an urgent workup, or can they potentially be managed quickly as an outpatient?
It really is an impressive system. This whole pathway feels like a high-stakes, incredibly organized triage process. Rule out the bleed first, then race against those hard time limits, 4.5 hours for TPA, up to 24 for thrombectomy, always thinking about salvaging that penumbra.
That's the essence of it: speed, accuracy, and adherence to evidence-based protocols to maximize good outcomes.
So as we wrap up, what's a final thought for our listeners to chew on?
Well, think about that distinction we just discussed, TIA versus stroke, being defined by the MRI, by the presence or absence of actual tissue death, even if the symptoms went away completely. Consider the penumbra, again, that tissue that was threatened but maybe recovered. How does knowing that the line between just a warning, TIA, and permanent brain damage, stroke, is often invisible clinically, only revealed by imaging? How does that change how urgently you think we should approach every suspected TIA, focusing on aggressive prevention to stop the potentially devastating event that might be just around the corner? It really emphasizes that a TIA isn't minor. It's a major warning.